Hello and welcome to the Headache Doctor Podcast. I'm Dr. Taves, your host. As always, it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. In today's podcast, we're going to talk about a comprehensive look at pain and how it leads to headaches and migraines. This is sort of a foundational podcast. I think this will be well loved from a lot of our listeners because we're going to get into the nitty-gritty of pain, understanding pain and how our body experiences pain, receives this pain signal, the environment the pain signal is received in. Those are key to properly assessing, diagnosing, and then treating headaches and migraines. A misunderstanding of pain is actually what will lead you down the road of medication. A misunderstanding of where the pain signal is actually coming from, not asking the question why over and over and over again. Those are all reasons why our healthcare system has failed you in a sense and led you down this road of medication without an answer as to what is actually happening. So what we're going to do is we're going to first lay out an understanding of the basic anatomy, so the anatomical structures that are involved in headaches and migraines. Then we are going to understand, we're going to talk about how we experience pain, the environment the pain is experienced in, how the pain signal travels to our brain, and then we're going to talk about the different tissues that are inflamed and what you may feel. This is where we'll get into the different types of sensations, whether it's sharp stabbing, dull, achy, pound throbbing. We'll talk about different types of headaches, and then we're going to bring it all together and sort of summarize why pain, the understanding of pain, tracing it back to the anatomical structures, why this all matters, and why it can benefit you to really understand this. Not only will it benefit you to understand this personally and give you a sense of potentially relief of, oh, there's actually something that has been missed, but it can help you advocate for yourself as you are going through our healthcare system and trying to find answers. It may also help you understand who you need to go see for treatment, and whether that's advocating with your primary care doc for a referral or just searching the internet for someone that can do this type of treatment. Okay, let's first look at understanding the basic anatomy. So the first things I want to talk about as a physical therapist in physical therapy school, we have a robust education in regards to our neurological system, our central nervous system, the brain, peripheral nerves especially, and how those nerves interact with the muscles and coordinate movements, things like that. But let's get it even more basic than that and look at the muscles, tendons, ligaments. So when we think about movement in our body, and I say the musculoskeletal system, we have muscles that have contractile tissue in them. So these are made up of little tiny contractile cells, that these fibers that will contract and relax and over and over again. Okay, so muscles themselves can be a source of pain or tension. And what's happening there is those individual fibers, let's say you feel a knot, there's a grouping of individual fibers that are contracted. And so they're not going through their normal flow of the day where they'll contract and then relax and contract and relax. They may just be contracted. Maybe you're asking them to do an amount of work over a long period of time that they're not necessarily supposed to be doing. One of the responses is sort of this response, a protective response of individual fibers just contracting. Now, when a muscle is relaxed, it receives blood flow. It allows blood to flow through the muscle. Muscles also help with a sort of a blood pump with our veins. And so a muscle just constantly being contracted is not a good thing. It also is a source of inflammation, and so we'll talk about that. We need muscles to get regular blood flow. We need that normal contract, relax, and so these knots or this constant tension is a problem. We've also got tendons. So tendons are the connection between the muscle and the bone. All right, so tendons will adapt to stress, just like muscles will. Tendons can increase in the amount of like collagen, or the tissue itself will become stronger, more robust. Tendons can also become inflamed. It's commonly understood that You can tear or strain a tendon to the point, it's commonly referred to as like a muscle strain, but oftentimes the tendon, the junction between the muscle and the bone itself, when a strain occurs, the tendon is actually the tissue that's disrupted enough to have inflammation and cause some issues. Ligaments, so ligaments are connecting bone to bone. Ligaments are what is actually holding our musculoskeletal system together. In the spine and in the neck in particular, the anatomy and the structure of the vertebrae are set up so that with gravity, they can respond to gravity and we can rest on each vertebrae, just the bones themselves. But the ligaments are to some extent holding those structures together. The ligaments are not necessarily intended to hold up our head entirely on their own, and they're intended to support the bones themselves, the vertebrae, as they support our head. And so ligaments can get irritated. One, if there's excess strain on a ligament, so if we are, it can either be in trauma or like a whiplash injury, the ligaments can take some sort of force which can damage the ligaments, or potentially it damages the ligaments and then the healing is healing with a scar tissue impact, and it can restrict movement of the ligament itself. A ligament, just like the tendons and just like the muscles, are always responding to stress, and they're also responding to lack of movement. So think of all of these tissues as being dynamic. If we add stress to them, that can be good stress that results in them being more resilient, or it can be bad stress, which results in inflammation or irritation. Lack of movement is also a problem with all three of these types of tissues. So muscles, tendons, and ligaments, if we do not move them and use their available motion, so ligaments have some laxity to them, tendons are connecting the bone to muscle, and the muscle is obviously contracting. If we don't move, each of these tissues will eventually respond with some sort of adaptive shortening or an adaptive response to that lack of movement. For example, one of the more immediate impacts you might see is, or relate with as far as an example, is holding your phone up to your ear. If you have been talking on the phone for, let's say, 20-30 minutes, you hold your phone up to your ear, and after that 20-30 minutes, you realize that your elbow is feeling stiff and irritated. Now, what's happening there is the joint itself, maybe the ligaments, maybe the muscle, there are those tissues that are telling you that it needs to move. So the body is intended to be dynamic. So when we talk about poor posturing, sedentary lifestyle, and incorporating movement into our day, that's catering to these three types of tissues: muscles, tendons, ligaments. Let's move to the brain. So in the brain, we have the meninges. So the meninges are made up of these tissues that wrap around the brain itself. There's different layers of the meninges. One of those layers is called the dura mater or dura mater, and the dura mater is one of the thicker tissues. As we dive beneath the dura mater, we have the subarachnoid space, and the subarachnoid space is where blood vessels live. And so what's interesting about the brain is the brain itself is this sort of, it's in a pool of fluid, and so it's just sort of floating there. And around the brain is this really thick tissue. It's a strong tissue. It's, surgeons, it takes very sharp surgical instruments to cut through it. And so our brain is fairly protected. When the brain is, when there's some sort of inflammation or pressure on the brain, what we normally feel is actually the meninges that are sensitized. We have what are called nociceptors, or pain receptors, that run through the meninges. And in the subarachnoid space is where we have the blood vessels that are going to actually perfuse our brain and the other tissues around the brain. And so the brain itself does not actually have the sensation of pain, but the dura mater, these meninges, this thick tissue that wraps around the brain and our central nervous system, that's where we can actually have pain, and it can be sensitized. So if there's inflammation in that area or pressure, for example, in a hemorrhagic stroke or something like that, if there's a rapid increase in pressure, that's where that sort of thunderclap headache would come from. And that is a headache that we would not want to see you for. You would want to go to the emergency room. But a lot of people have, well, headaches or pain in your head. And so a lot of people assume that their brain has a problem. Your brain is actually likely not the problem if you're experiencing pain. At least that's not where the brain is picking up the pain signal, because your brain doesn't have nociception. The dura mater might be sensitive, the meninges might be sensitized, the blood vessels in that subarachnoid space may be sensitized, but all those are sort of surrounding the brain itself. And so that's important to understand, and we'll talk more about that. Brain tissue itself does not have pain receptors. That's another important piece of information that is helpful to understand. And again, we'll jump into that more in a little bit. So let's talk about how we experience pain. And this is one of the key elements if we're truly going to understand headaches and migraines and where the pain is coming from. All right, so we have different types of nerves and different types of nerve endings. The types of nerve endings that pick up and send pain, they're called nociceptors. So nociception is the perception of pain. So that's important to understand. One, like I said, the brain does not have nociceptors, and then certain tissues do have nociception, okay? And so let's say, for example, that the brain is picking up a signal of pain or something that would be pain, inflammation from a certain area, and maybe that area does not have nociception. One thing that can happen is, one, the pressure, like in the example of a stroke, pressure on other tissues that then become inflamed can then become sensitized. And so sometimes tissues that have inflammation around them become sensitized and then can send nociception or can send pain. So inflammation can change the experience of certain tissues. So inflammation, this is also something that we need to understand. So inflammation is the actual process of sensitizing the tissue itself. It's sort of the response the body has to some sort of tissue damage. And the inflammation itself is made up of cytokines, and these are just types of proteins that are sending a signal of pain. It's sort of like the alarm bells are going off. Inflammation might be seen as your smoke alarm in your house. It's sending an alarm. It's kind of the initial response of something is wrong. Maybe a better example would be the actual smoke. And so with that, something is inflamed. When we have pain, we're going to assume that there's inflammation of some type, because inflammation is where pain signals start. I've used the example of bumping your elbow. If you bump your elbow, the trauma itself triggers an inflammatory response, which then signals pain. All right, so inflammation can be impacted by all sorts of things. There's acute inflammation. Inflammation itself is not a bad thing. Inflammation acutely is a very good thing. It's how our body starts the healing process. It's an appropriate response to trauma. And so inflammation we're not going to put that in the bad category. Now, chronic inflammation, we can see that as an improper response. So an improper response, inflammatory response, is something that we should consider when working with someone that has headaches or migraines. There's all sorts of different reasons or explanations as to why someone might have an improper inflammatory response or chronic inflammation. I've talked to functional medicine doctors. Dr. Morris is probably the most, has provided the most helpful information in regards to understanding this inflammatory process and why someone would have an improper inflammatory response. It can be impacted by your GI system, so the foods that we consume and impacting our gut can then impact our inflammatory response throughout the rest of the body. Stress can also impact our inflammatory response, and then environmental factors like toxins, things like that. And so there's outside influences that we may not be aware of that are impacting our inflammatory response. So let's say we have some sort of tissue damage, and then we have inflammation. So those two things, that's a normal response acutely, but chronically that can be a problem. It can also be a problem if we have hyperinflammation to the actual trauma itself. And we'll talk about that in a little bit. But again, this is all going into how we experience pain and understanding the process of the pain signal, how we receive it, and the environment that it's received in. All right, so let's talk about the brain's perception of pain. So we have some sort of tissue damage, let's say the muscle, the tendon, the ligament, we have inflammation. If that inflammation is a proper response, it would be an acute inflammation. It's the body starting this healing process, letting us know something's wrong. Now, we don't actually experience pain as a one-to-one connection, meaning it travels through a peripheral nerve. So this is a nerve that's exited the spinal cord. It's traveling through the spinal cord, and then it actually accesses our brainstem before it hits our cortex. Now, this is important to understand. So the brainstem, as it travels up and through the spinal cord through the brainstem kind of juts down partially outside of the skull itself. And then the cortex of the brain is what we actually, that's where we perceive what's happening. So we realize any type of sensation, this isn't just pain, visually, our sense of smell, hearing, any sensation we have is going to actually be realized when it hits the cortex. So we don't know what's happening from the site of an injury with inflammation. The pain signal's got to travel through the brainstem, and then we realize what's happening when it hits the cortex. Now, why that's important is because there's several different factors in what the brain can, the environment the brain perceives the pain in, and whether it's psychosomatic, the psychology behind what we perceive the pain being, to the actual pathway the pain travels through, and potentially other influences or sensory inputs that meet up in the brainstem, and then the brain is having to decipher the location and type of sensation. But the brain perceiving pain, it puts pain in a subjective box. So pain is subjective. I've talked about this relatively recently in my podcast, but it's worth repeating. So the brain is going to receive a pain signal, and if you have a history, so trauma, it can be emotional, psychological trauma, that can actually manifest itself as physical pain. So sort of an improper response to potentially something physically that's happening in your body. Your brain can also manifest pain when there's no tissue damage, and so your brain can be making pain up. Now, for most of the people we see, for the majority of them, that is not the situation. They're not making pain up. And for the most part, we can trust pain, but pain itself is sort of, it's deceptive in nature. Now, there are sort of rules or parameters so that when we have someone that comes with a certain type of pain pattern, we can trust that at least one of 3 or 4 things are happening. Now, the problem is that when we're taking pain and we are assuming that it's a one-to-one connection. So a few things are not happening. We are not, we're not connecting the pain to potentially any emotional or psychological trauma or psychological impact that might be distorting the severity, the intensity, the frequency of those symptoms. We're also assuming that if you have a pounding-like sensation, sharp pain behind the eye, we're also assuming that that is connected to your head. And there's no reason to look outside your head. So we're assuming that the location of pain is accurate. So we're assuming that pain itself is objective when we should be seeing it as subjective. And seeing it as subjective really opens up a lot of doors as far as what is actually happening here, instead of just assuming your brain or your head has something wrong with it. All right, let's look at the different types of tissues that might be inflamed, and then what you would feel as those tissues are inflamed or irritated. So sharp stabbing burning, this is connected to nerve pain. If you have sharp stabbing burning, this could be a trigeminal neuralgia, occipital neuralgia. The neuralgias fall into this category. Now, traditionally, you would be sent down the medical model of pharmaceuticals, anti-seizure medications, or maybe a local injection to reduce inflammation in the nerve itself. Now, it's not to say that those interventions never work, because there are times where the nerve itself is inflamed, okay? And we'll talk about why we need to continue to ask the question why for nerve pain in a second. Let's move to dull achiness. So dull achiness is going to be consistent with more of a tension type headache. So muscle pain is going to present as a dull achiness. And so what we're picking up here, what our bodies or our brains are picking up, is sort of this low grade constant pain signal of tension. Now obviously that tension will fluctuate throughout the day, but I describe tension headaches as coming from just the general tension that you'll experience in your neck, in your shoulders, in your suboccipital area. So people that have tension headaches, or this strap-like headache in their forehead, they typically have a lot of areas that need attention. It's sort of general tension that's built up in their shoulders and their neck and their head. So that dull achiness is going to be connected to muscle pain. And then we have pounding, throbbing sensation. So this is why, or part of the reason why, migraine symptoms of pounding, throbbing sensations on one side of the head have traditionally been thought of as a blood vessel problem. Now, that's been sort of, that's a little bit archaic to think that migraines are a blood vessel issue, but that thought is still out there. I mean, there are changes in the blood vessels themselves that can be seen with imaging when someone's actively having a migraine. But the idea here is that the throbbing sensation has to come from blood vessels. And why would things like propranolol, like blood pressure medication, heart medication, why would these things impact your migraine experience at all if it wasn't a blood vessel problem? Okay, so you can see here a little bit of what I'm getting at. If you have sharp stabbing burning pain, it's a nerve problem, so we need to treat the nerve. If you have dull achiness, that's muscle pain, so do some stretches and try to reduce stress. If you have a pounding, throbbing sensation and you have these other symptoms like a visual disturbance, nausea, things like that, that's a migraine, and we need to treat that as maybe we're treating the blood vessels themselves, taking stress off the blood vessels, or we're treating it as this spontaneous neurological event. But the problem with all of this is we're having a one-to-one relationship with pain. We're taking sharp stabbing burning pain and we're assuming that there's a problem with the nerve. We're seeing dull achiness and we're assuming it's muscle pain. We're receiving pounding, throbbing, and we're assuming there's a blood vessel problem. Now, don't hear me wrong. Those types of pains are consistent with nerve, with muscle, with blood vessels. But we need to continue to ask the question why. Why is the brain perceiving your nerve as having a problem? Why is the brain perceiving your muscles as being achy or tense? Why is your brain, this one's probably the most applicable, why is your brain perceiving a pounding, throbbing sensation? All right? And when we're treating someone and diagnosing them, do we stop at those specific tissues, or do we keep asking the question why as to what might be causing the nerve to have inflammation around it or irritation? What might be causing this muscle tension? And especially what might be causing this pounding or throbbing sensation? And so to bring it all together here, if we're understanding pain and we're treating it as subjective, the parameters that we can build around head and facial pain. So I'm gonna say just about any type of headache or migraine, any type of head or facial pain, whether that's sharp stabbing, dull achiness, pounding, throbbing, what we have to understand is that there's referred pain from the neck that can travel to the head and does travel to the head or the face. There's interaction with the trigeminal nerve. There's interaction with other sensory inputs in the brainstem. The brainstem is the key to understanding headaches and migraines. And the brain and the perception of pain as it hits the brain can be impacted not only by like systemic inflammation, our perception of the pain, the psychology of it, and so the intensity, the infrequency, the type of pain can be impacted by all these different things. So to assume that there's this one-to-one connection will lead you down a path that allows us not to, like, we're not testing anything outside of that. I'll use the example of a heart attack. If you have chest pressure and shoulder pain, you will very, very likely, unless you're seeing a bad provider, you are not going to be sent to a physical therapist. If this is a new onset of those symptoms, likely you are going to be sent to the emergency room. Why? Because we're going to assume that your heart has a problem, that your heart is lacking oxygen. And the way that we experience that is by chest pain, shoulder pain, okay? So in this world of headaches and migraines, the connection between the neck and your head and face is so strong that we should be assuming, just like we do with heart attacks, that if your head hurts, if your face hurts, and let's say you've screened, because just about everyone we've seen with a new onset of some sort of debilitating pain, they go through our emergency room system, they scan, okay, you're not dying, you don't have a stroke, you don't have anything like that. Now, they stop there. They're not going to provide you with answers past that. But what should be assumed is that just like a heart attack, you have shoulder pain, we think the heart, just like your head, if you have head or facial pain, we should assume the neck. Now, I've got other podcasts that talk about why our evaluation in the neck falls short and why even assuming that it's a neck problem, sometimes it's hard to really find the answers, and that goes back to movement problems and the type of injury we're dealing with. But understanding that head or facial pain is subjective, that the location, that the type of pain signal we're experiencing can't necessarily be trusted is kind of how we have to move forward. Now, does that mean pain itself is just totally subjective? We can't trust anything? Absolutely not. So what we can trust is that when you have the heart attack, you'll have shoulder pain, okay? So there's consistency within parameters, all right? So when someone comes to us and they have a left-sided throbbing, pounding ram's horn presentation, typically their upper cervical spine, their upper neck on the left side, specifically in a few joints, will be the problem. Now, I'm not taking that pain as a one-to-one connection of saying, well, your head has to be the problem. I'm assuming that there's more to that. But what we see is the consistency of the variability, if that makes any sense to you. So the variability is the brain doesn't necessarily get the signal right, but when it doesn't get it right, it's usually consistent in that, okay? So there's reliability and validity, okay? So accuracy and reliability. So the brain is not necessarily accurate on what it's telling us, but it is reliable, meaning that same signal can be trusted over and over. So that same type of presentation, as providers, we can source it back to the same types of things. So that strap-like headache on your forehead, we can source that back to muscle tension, neck tension, general tension through the body. A more specific ram's horn presentation, maybe occipital neuralgia-like presentation, pain behind one eye, that is going to be more of a specific joint problem in the neck, and typically it's on the same side as the issue. If you have temple pain or pain in your jaw, especially in the morning, I'm going to assume that has something to do with your jaw or tension that's built up in your jaw, or maybe you have an airway or breathing problem. So there are consistencies in what we see in these patterns. So the type of signal and pain that someone experiences is super helpful. The information is super helpful. We just can't assume that because your eye hurts, you have an eye problem, or because you have hypersensitivity to light, that you have an eye problem, or because you have hypersensitivity to smells, that it's something outside of your neck. We can't assume those things because the brain is experiencing pain as a subjective experience, and it's confusing not only the location, but the type of inputs and the hypersensitivities that come along with that intense pain signal make it even more confusing to really understand what's going on. But what's exciting is in our practice here at Novera, we have found these consistencies within the variability of the pain and how it presents. So we can have confidence with these types of patients that we see over and over, and really any type of head or facial pain, we have confidence that we can find something and source it back to something. And we look at that through the lens of, do we need to understand if inflammation is impacting this? Is there a psychological component to this? What is the musculoskeletal problem, the muscles, tendons, ligaments, and how do we restore function to that musculoskeletal system? And that's why as physical therapists, I feel like we should be in this niche because we're understanding movement, we're restoring the musculoskeletal system. That's where a lot of this inflammation and pain can actually stem from. And then we're able to provide solutions outside of medication, because I can't even prescribe meds, and I wouldn't want to, because it forces me to help someone with pain management outside of medication. So there you have it. There's an in-depth look at pain and how our bodies are responding to pain, why it's important to understand pain is subjective, and how assuming that one-to-one relationship can lead us down the road of medication. This is the Headache Doctor Podcast. I would love it if you appreciate this podcast and what we're doing, that you share this with someone that you know that could really benefit from it. And of course, give us a 5-star review wherever you listen. Thank you for listening to the Headache Doctor Podcast, where it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear and dependence and thrive in everything you do.